He had AFIP, and Professor of Medicine Emeritus at George Washington University. And this morning he'll be speaking on the spectrum of hepatopathies. Dr. Zimmerman?
Thank you very much, Dr. Harris. It's a pleasure to be here. I'm neither a veterinarian nor a pathologist, but I am interested in drug-induced liver injury. And what I'd like to give you this morning is an overview of drug-induced liver damage in man, and hope you see where it applies to disease of animals. And as I said a few minutes ago, the tissues really are much the same, despite their different apparent origins. First slide, please. Wow, that's a bright light. Okay. All right. Well, what is the importance of drug-induced liver disease? It probably accounts for about 1 out of every 10 cases that we call hepatitis. Actually, in patients over the age of 50, almost half of the cases of jaundice are due to drug-induced disease. It becomes a very important point. Furthermore, in what we call fulminant liver failure, massive necrosis, that leads almost always to death, 1 out of 4 of those cases are due to drug-induced injury. If you have intrahepatic cholestasis, it looks like obstructive jaundice, but isn't. The most likely diagnosis is drug-induced cholestasis, although there are many other causes. And finally, there are some chronic liver injuries that are important. So I'm going to touch bases on all of these facets, and hope there's time for you to ask me some questions. Slide. I did something wrong here, obviously. That's the advance, huh? Well, the topic was a spectrum. This is a spectrum. It summarizes the talk. Drug-induced injury can occur because the agent is toxic or because the exposed individual is uniquely susceptible. The injury can be to the parenchyma or it can be arrested bile flow. It can be acute disease or it can be chronic disease. The injury may come on abruptly, as when there's an overdose of a toxic agent. Tylenol, acetaminophen, for example, leads to acute injury almost immediately within a day or two. Or it may take 1 to 5 weeks to begin after the drug has been started, when it's due to immunologic idiosyncrasy. Or it may occur anytime, weeks or months after starting it, when it's metabolic idiosyncrasy. And then the injury may be only to the liver, may involve other organs, or may involve systemic manifestations. And I'd like to touch on some of these features. Well, how about acute injury first? As I said, drug-induced acute injury may be to the parenchyma or may be arrested bile flow. And if to the parenchyma, it may be necrosis or fat. And even cholestasis comes in a couple of models, and I'll say more about that. Well, necrosis due to chemical agents may be either zonal or may be non-zonal. Now, intrinsic toxins like carbon tetrachloride, mushroom poisoning, and a host of other agents lead to zonal necrosis, especially in zone 3. But most drugs lead to non-zonal injury. There are, however, several drugs that lead to zone 3 necrosis. Acetaminophen, halothane, and several other haloalkane anesthetics, and curiously, ketoconazole. What is the point I'm making, or would like to make? That it's zone 3 is the place where the cytochrome P450 system is concentrated. And therefore, necrosis that's due to a flood production of toxic metabolites will be in zone 3. So this is, whereas most drug-induced injury turns out to be non-zonal. To illustrate, this is the necrosis of carbon tetrachloride in man. Efferent vein, central vein, and here is a sharp cookie cutter-like lesion that carbon tetrachloride produces. And here's a very similar injury. And this is a patient who died with halothane necrosis, halothane jaundice. And here is another similar injury. Here's a portalaria, and here you see zone 1 and 2, and here again is zone 3 and 2, and here again is zone 3 necrosis, and fatal acetaminophen poisoning. On the other hand, most drugs lead to non-zonal injury. This happens to be a case of acute hepatocellular injury in a patient who has been taking Aldomet, antihypertensive drug. And as you can see from one end to the other of the lobule, there is it's a uniform injury, degeneration, necrosis, acidophilic bodies. In the extreme, this leads to massive necrosis. This happens to be a case of massive necrosis in a patient who has been taking isoniazid for tuberculosis. And you can see there's nothing left of massive necrosis, a few little feebly regenerative islets, but massive destruction. That can be the extreme of either non-zonal or zonal. Generally, in zonal necrosis, even when it's severe, there is you can still recognize lobular architecture, even though the parenchyma is almost destroyed. This is more characteristic of the non-zonal. Very serious entity, hepatocellular injury, site necrosis, drug-induced necrosis in man, with a mortality rate of at least 10%. You may have never heard of this drug. It's a drug used to treat gout and arthritis half a century ago, but that, when it led to necrosis, had about a 50% case fatality rate. Halothane injury. Halothane jaundice, again, has a very seriously high mortality rate. Iproniazid, a drug related to isoniazid, used to treat depression a quarter century ago. In our series we looked at, 15% mortality. Dilantin jaundice. These are very high figures. Drug-induced hepatocellular jaundice is a serious entity with a serious outcome. This is the other kind of cytotoxic injury of acute injury due to drugs. Microvesicular steatosis. Cells filled with finely fat droplets and the nucleus not displaced, in contrast to the usual fatty liver. This is typical of the injury you see when parenteral tetracyclines. This is what one sees in fatal aspirin poisoning. A thiamine leads to injury like this experimentally. It's a lesion that is characteristic of acute toxic injury. Liver looks like in Rye syndrome. Fatty liver pregnancy. Microvesicular steatosis is one of the classic lesions of toxic injury. The known causes, of course, as I said, are intravenous tetracycline or even other parenteral routes. Valproic acid, the anticonvulsant, leads to some degree of microvesicular fat in animals as well as in man. Amiodarone, the antiarrhythmic drug that leads to other injury that I'll mention later, also can lead to this microvesicular fat. Aspirin poisoning. Hypoglycemia. In Jamaica, a syndrome called Jamaican vomiting sickness is due to the ingestion of the unripe fruit of a tree there called ackee. And the agent in it, hypoglycemia, leads to severe vomiting and also to severe fatty liver looking just like the section I showed you. Alcohol rarely leads to what's called the alcohol foamy liver, and there are other intrinsic toxins that they use experimentally. Puromycin, for example, leads to the same thing. What is the biochemical reflection of the injury I'm talking about? Drug-induced hepatocellular jaundice, drug-induced necrosis leads to very high aminotransferase levels. The AST and ALT may be 100-fold the normal, 3,000, 4,000, 5,000 units. And alkaline phosphatase levels are very modest. This resembles severe viral hepatitis. And the microvesicular steatosis leads to somewhat lower levels, but still quite briskly elevated. You remember the normal is down below 40 units in man. In various species, of course, as you know, it differs.
And the clinical features resemble fatty liver pregnancy, but the biochemical ones are listed, shown here. This is a serious entity, 10 to 50% mortality, and microvesicular steatosis also is a serious entity. This can be reproduced, of course, in animals with tetracycline and with a number of other toxins. The other extreme, the other end of the spectrum of acute injury is cholestasis. As this is a nice example, a patient who had been on an anabolic steroid, a C17 alkylated steroid. You see the liver looks essentially normal with the exception of bile casts in the canaliculi. There are two kinds of drug-induced cholestasis that differ in that one has a little more, let me put it differently. One is exemplified by chlorpromazine jaundice and another by anabolic steroid jaundice. In anabolic steroid jaundice, the liver shows only bile casts in the canaliculi. There's hardly any parenchymal injury. There is hardly any inflammation. It is simply a clean, pure cholestatic injury. On the other hand, the cholestasis due to chlorpromazine is characterized by a little more parenchymal injury. Transaminase is a little bit higher. The biopsy shows a little more abnormality, occasional acidophilic body, and there is usually some degree of portal inflammation. We call this one hepatocanalicular because of the fact a little more parenchymal injury, and this one canalicular. Biochemically, they differ. Although both of them have rather modest transaminase values, the alk phos levels and cholesterol levels differ. This resembles obstructive jaundice, very high alkaline phosphatase levels, and impressive hypercholesterolemia, whereas this shows very little alk phos elevation, very little cholesterol increase. Two different biological reflections of cholestasis. So what I've tried to say is that drug-induced acute injury may be hepatitis-like, necrosis, very high aminotransferase levels, modest alk phos values. Obstructive jaundice-like, modest transaminase, high alk phos levels, the curious kind of cholestasis that we see with steroids, and the microvesicular steatosis. And then some drugs lead to mixed patterns, not just pure hepatocellular, but a little cholestatic features, and some of these show a little more parenchymal injury. This is the spectrum of drug-induced acute injury. But also important is drug-induced chronic injury. And again, it may be cytotoxic, that is mainly in the parenchyma. It may be mainly arrested bile flow. There are vascular lesions, granulomas, and neoplastic. I'm not going to say any more about granulomatous lesions due to drugs, other than to say at least 60 drugs have now been incriminated in the ability to lead to granulomas in the liver. And when one encounters granulomas in the human liver, the first consideration is it due to a drug or is it due to one of the infections that leads to granulomas? And I'm sure the same lesion could occur in animals. But let's first talk about the chronic parenchymal lesions. And there are 5 lesions we want to mention to you. One, chronic active hepatitis. Now, chronic active hepatitis, to those who look at human disease, is a very familiar concept. It refers to chronic necroinflammatory disease in which there's expansion of the portal areas. There is what we call piecemeal necrosis, that is, and I'll illustrate that in a minute, inflammation, necrosis at the border of the lobule and the parenchyma, and usually fibrosis capturing groups of cells around the portal area. There are several causes: chronic viral disease, autoimmune disease, Wilson's disease can do it sometime, and drug-induced injury. And that's what I'm going to talk about. So it's an entity that we see due to several things, but I'm referring here to that due to drugs. And there are a few drugs that do it particularly: Aldomet, hepaverine, nitrofurantoin, sulfonamides, the tricrinafin, a drug that was briefly in use. Another chronic lesion is chronic fatty liver, particularly due to the methotrexate drug used to treat psoriasis and some neoplastic lesions. Several anti-cancer drugs do this, and as you know, large doses of glucocorticoids can lead to fatty liver. Then there's a curious entity, a curious entity called phospholipidosis that was reported first from Japan about 20 years ago that I'll have more to say about in a minute. But it's a lesion characterized by accumulation of phospholipids in the lysosomes, giving the liver a somewhat granular appearance, and diagnosed only by seeing the abnormal lysosomes. And they're often accompanied by lesions resembling alcoholic liver disease, and I'll say more about that in a minute. And finally, any one of these lesions can lead to cirrhosis. Well, this picture is showing a chronic hepatitis injury in a patient who's been on Aldomet, alpha-methyl-dopa, for a period of about 4 months. You see here is a grotesquely expanded portal area, and here at the periphery of the lobule, you see you can't see where the limiting plate is because there's overlap of inflammation and necrosis here, and again here. This is typical chronic hepatitis. It could look like this in chronic hepatitis B. It could look like this in autoimmune chronic active, and I said, this is due to methyl-dopa. This is another chronic hepatitis in a patient who had been on ticrinafin, a drug that was pulled off the market. And you can see not only is there the same kind of injury, but there's also, I'm sorry, it isn't all on this slide, there's also a pseudolobule that had been formed. And they're going on to cirrhosis, actually. Well, this is a very curious entity, this drug-induced chronic hepatitis. It resembles what we call autoimmune disease. Autoimmune chronic active hepatitis is an entity in which there is circulating antibodies, anti-nuclear antibody at the LA plasma factor, anti-smooth muscle, the very high globulin levels, and where there is continued progression with self-destruction until there's liver failure and death, unless there's treatment with steroids. Now, this kind of autoimmune hepatitis is idiopathic, but the drug-induced chronic hepatitis mimics the autoimmune kind very closely. Just as the autoimmune chronic hepatitis shows the female predominance, about 90% of these patients are females. This drug-induced injury has the same kind of antibodies in the blood circulating and striking hyperglobulinemia, strongly suggesting that this has an immunologic pathogenesis. The drugs that have been incriminated, oxyphenicillin, a drug that was in a cathodic preparation 20 years ago and called Dialose Plus, no longer available in this country, but this was the first that reminded us of it. Nitrofurantoin, the antimicrobial agent used for urinary tract disease, is probably the most commonly implicated in this disease now. Methyl-dopa, clomethazine, an analgesic used in France, papaverine, an anxiolytic drug, and this is another one. Number of drugs that do this produces curious lesion. The second kind of cytotoxic injury that's chronic I want to mention is fatty liver. Among the causes of drug-induced drug causes of fatty liver, methotrexate is most prominent. Methotrexate, as you know, is an antifolate compound that was been used for the treatment of leukemia since mid-century, for 40 years now. During the 50s, kids with leukemia who were treated with methotrexate were found to have fibrosis and even cirrhosis. In the subsequent several decades, this began to be seen in patients with psoriasis treated with methotrexate, where cases of fatty liver and cirrhosis were reported, and today it's now an established and recognized phenomenon that methotrexate can lead to this kind of steatosis, macrovesicular, and it may, as in the case I'm showing you, go on to cirrhosis. This is a patient who 3 years earlier showed the fatty liver, and this is what the liver looked like after continuing on the drug. Now, a huge number of patients have received methotrexate. Most have not developed this injury. What leads to it? It's quite clear that intake of alcohol enhances strikingly the likelihood that methotrexate will lead to fatty liver and cirrhosis. People do not have to be alcoholics for this to apply, but anybody who's been taking methotrexate should simply be forbidden to drink at all. Obesity and obese diabetics particularly enhance the likelihood of toxicity. Furthermore, curiously, the frequency of the dose. When the drug was given every day, even in doses that were no greater ultimately, liver injury was far more likely than when separated by weekly intervals. There's some evidence that total size of the dose, total dose and individual size played a difference and duration. So this is a very curious form of toxicity. Furthermore, it is very difficult to reproduce in experimental animals, even though it's clearly an intrinsic toxin. And we'll talk about the criteria in a few minutes. Even though it depends on dose and its own characteristic, the fact is that in experimental animals it takes manipulation of circumstances that are elaborate to get injury produced by methotrexate. A few words about a very curious lesion called phospholipidosis. 20 years ago, in 1969 and 70, there were cases reported from Japan in patients taking a drug called, the trade name Coralgil, 4,4-diethylamino ethoxyhexestrol. I'm sure you'd rather call it Coralgil. They found that patients with coronary disease being treated with this drug developed enlarged livers. And when biopsies were done, they found that the livers showed a curious granular appearance. And on an electron microscopy, they found that the lysosomes were bizarre. Furthermore, some patients were found to have Mallory bodies as well as this lesion, and fat and even cirrhosis, leading to what some of us now call pseudo-alcoholic liver disease. How many of you know the Mallory body story? Everybody? In 1911, Professor Mallory in Boston described what he called, what has since been called alcoholic hyaline of the Mallory body. And it's severe alcoholic liver disease. Let me see if I have a, I'll come back to you. Which one? I'll come back to it, the earlier one. In patients with severe alcoholic liver disease, he found within the hepatocytes this curious dendritic, eosinophilic, hyalinized, intracellular morphologic element, which was seen frequently in most alcoholics with severe liver injury and was thought to be seen no place else, and it's been called alcoholic hyaline now for 75 years. In recent years, we've come to recognize that there are other causes. And I'm not going to run through all the causes, but I want to draw your attention, as I'm illustrating right here, that one of the causes of lesions, just like alcohol, just like those of the alcoholic, is amiodarone and the Coralgil and another drug I'm going to mention. Here is a patient who's been on amiodarone, and these very elegant Mallory bodies were seen in his liver, and these are quite characteristic. They go back to my story then. The patients who were on Coralgil developed curious hepatomegaly with foamy cells, abnormal lysosomes, and some also had changes that mimicked alcoholic liver disease. Well, nobody paid any attention to it. These were cases only in the Japanese literature, or in the world, some reach the world literature, but a drug used only in Japan, and very little attention was paid to it until a few years later, in the late 70s, a drug being used in Europe called perhexylene maleate in patients with coronary disease also led to exactly the same change. And again, the drug wasn't used here, was not permitted here, didn't draw a lot of attention until we recognized 4 or 5 years ago that amiodarone, the antiarrhythmic drug, also leads to exactly the same lesions. Now, sometimes the patient with phospholipidosis may show curious changes like this. Looks like there's some necrosis here, and one wonders what the lesion is. And if you look at the electron microscopy, you'll see the cells are full of these curiously abnormal lysosomes that are virtually diagnostic of the entity. And those lysosomes are packed with phospholipids. And the other lesion, as I just showed you, is that there may be the accompaniment of these Mallory bodies, pseudoalcoholic liver disease. This lesion may well go on to cirrhosis, as illustrated here. This is a patient who had been on amiodarone, and I think you can see that there is indeed architectural distortion, pseudolobulation, and cirrhosis. What are the lesions, drug-induced lesions that can cause cirrhosis? Certainly, an important one is chronic active hepatitis, as I showed you a few minutes ago. That kind of necro-inflammatory disease, if the drug is continued, may lead to cirrhosis and death. Methotrexate leads to cirrhosis as a consequence of the steatosis and associated changes. Amiodarone, which leads to phospholipidosis and pseudoalcoholic liver disease, can lead to cirrhosis. And then there are several entities I'm going to talk about in a minute. One that leads to a pseudo-primary biliary cirrhosis, a pseudo-sclerosing cholangitis, and then there's several other lesions I'm going to touch on in a minute. Well, chronic drug-induced injury may also be cholestatic. And there are two kinds of chronic cholestasis it can produce. We both face a handicap. I tend to talk about disease that you've had nothing to do with, and vice versa. But the primary biliary cirrhosis is a lesion in man, which, I say in humans, which involves mainly women, and which is characterized by striking chronic cholestasis. There is very little jaundice, strikingly high levels of cholesterol, striking deposits, xanthomatous deposits around the eyes and in the skin, and the elbows, and ultimately death and liver failure. Striking chronic cholestasis, characterized microscopically by non-suppurative cholangiodestruction. The portal area bile ducts undergo destruction, and ultimately there is ductopenia with disappearance of the portal area ducts, and there is a progressive destruction of those ducts. That's a spontaneous disease, probably of autoimmune pathogenesis. The other kind of cholestasis I want to talk about is called sclerosing cholangitis, in which there is distortion of the biliary tree, inflammation, constriction, partial obstruction. It's most often a complication of inflammatory bowel disease, ulcerative colitis. Those are two diseases having nothing to do with drugs. But drug-induced injury may mimic both of them. Acute cholestasis, such as that due to chlorpromazine that I mentioned before, may instead of subsiding, may in some instances remain for years with a chronic cholestatic lesion, just like primary biliary cirrhosis. A number of drugs have been incriminated. Adjmaline, a drug which resembles quinidine a little bit chemically, leads to acute cholestasis in man, and also may lead to chronic cholestasis, just like primary biliary cirrhosis. Bactrim, you're all familiar with the sulfonamide trimethoprim combination, leads to cholestatic jaundice often, and in some instances may lead to a chronic cholestatic syndrome, just like primary biliary cirrhosis. Chlorpromazine is the one that is most prominent in this regard. As I'm sure you know, chlorpromazine has been known to cause acute cholestasis since the early 1950s. In fact, chlorpromazine jaundice probably is as responsible as any other drug for drawing attention to drug-induced injury and starting the wave of studies that have occurred since then. Well, chlorpromazine jaundice, instead of subsiding, may in some instances lead to a chronic syndrome that may go on for years and often will resolve ultimately, but may lead to a fatal outcome. Cyproheptadine, another drug, haloperidol, drug that is used like chlorpromazine and does much the same thing, and several other agents, all that are known to lead to the same kind of injury. However, the other very interesting chronic cholestatic lesion is the one that is seen, that mimics sclerosing cholangitis. Patients who have metastatic colonic carcinoma to the liver are treated by infusion of floxuridine into the hepatic artery by pump. And that infusion leads regularly to injury to the biliary tree. It may be so trivial nothing else is noted, or it may go on to a lesion just like sclerosing cholangitis, in which there is inflammation, fibrosis, distortion of the biliary tree, and it may even go on to cirrhosis and a fatal outcome. The other cause of it is that patients with echinococcus cyst who are operated and the cyst is treated with formalin may now have, as a result of the toxic effect of the formalin on the biliary tree, lead to the same lesion. Again, then a chronic cholestatic lesion. Some very interesting vascular lesions are seen with drug-induced injury. Hepatic vein thrombosis, which leads to a syndrome called the Budd-Chiari syndrome, one in which there is, as a result of occlusion of the hepatic vein, striking congestion of the liver, secondary portal hypertension, severe ascites, and since the obstruction may involve the vena cava as well, edema, and usually death and liver failure. Now, there are many causes of it. I think maybe. No, I didn't include it. There are many causes of the Budd-Chiari syndrome. Polycythemia vera, other myeloproliferative syndromes, the trauma, neoplasm, infection. But about 1 out of 10 of the cases, 10% of reported cases are due to taking oral contraceptive pills. And it's apparently the thrombogenic effect of the oral contraceptive, of the estrogenic component that leads to the clotting. Probably many of the patients have a latent myeloproliferative condition which is further provoked by the drug, but there are at least 100 cases of this been reported. Another lesion I want to talk about is VENO-OCCLUSIVE disease, and I'll have more to say about that, and then several sinusoidal lesions that I'll come back to. Well, this is a picture of an autopsy section in a patient with the thrombosis of the hepatic veins, and here is a sublobular vein showing an organized clot. And as you can see, there is striking century zone 3 and perhaps zone 2 necrosis as well. The patient will either die in liver failure, go on to develop a congestive cirrhosis, or sometimes may improve strikingly if the cause is removed. Despite the fact that many of the patients who develop this syndrome while on the pill have an underlying thrombogenic entity, the risk when a controlled study is done is more than twice as great. This should be 2.3, not 2.7. Is more than twice as great for women on the pill than on a control group. There is a risk. There are not many cases, but it has been documented. Another cause of congestive hepatopathy due to drug is VENO-OCCLUSIVE disease. And this is a biopsy from a child who had been on anti-cancer therapy showing a occluded venule and showing the central congestion. What are the causes of this? Let me remind you that the lesion includes both necrosis and congestion, and there may not be complete occlusion of the central vein. In other words, fibrotic partial obliteration and injury to the parenchyma both contribute to the lesion. What are the causes of it? Well, is a well-known entity due to plant toxins. It's been known since the end of the 19th century that animals grazing on plants containing peroxidine alkaloids could develop VENO-OCCLUSIVE disease due to those alkaloids. Studies that were done in this country and in Canada at the turn of the century confirmed that. And this was a disease of stock in Nebraska and in Texas and in other parts of the world. Man has also been involved in, particularly it drew attention on the island of Jamaica, where children who were given, how's my time going? Children who were on Jamaica who had various illnesses were given bush tea, a decoction of Senecio plants that contained peroxidine alkaloids, and these children would develop VENO-OCCLUSIVE disease, and that would lead to death in about a third of them or a fourth of them, to recovery in about an equal number, and to chronic disease in the remainder. A very serious entity seen in various parts of the world. We thought there wasn't much of it here. Occasional cases were seen in southwest United States, but we have now seen it particularly in patients being treated for neoplastic disease with various anti-cancer protocols. And a number of drugs have been incriminated selectively, but by and large it's worth remembering that the anti-cancer protocols containing the various antimetabolites and containing the alkylating agents are likely to do it. Furthermore, X-ray alone, X-ray to the liver may lead to VENO-OCCLUSIVE disease, so-called radiation hepatitis. And a combination of X-ray radiation and anti-cancer treatment can lead to VENO-OCCLUSIVE disease. Alcoholic liver disease has some of this, tyrosinemia and a familial immunodeficiency state. It's a very important lesion, especially in individuals getting anti-cancer therapy. Well, another fascinating entity is called Pileosis hepatis. Can't get the whole thing in, huh? Pileosis hepatis showing blood-filled lakes. It's an old entity. It's been known for 100 years, but nobody paid attention to it. Until after the midpoint of the century, when people began using anabolic steroids as chronic treatment, began seeing patients who at autopsy would have these curious pileotic lesions, these blood-filled lakes. And the most important cause in man, is the anabolic steroid. One may see this in experimental animals too, and a number of drugs are done. And one way of producing in animals is phalloidin. Phalloidin, which leads to dramatic lesions like this, but several other drugs have also done this. Pileosis hepatis, the pathogenesis is not clear. Debate whether it represents a lesion of the sinusoids or whether it's some kind of imminent necrosis. Most likely a sinusoidal lesion. Another very interesting sinusoidal lesion is this one. This is central vein, and this is curious dilatation of the sinusoids in zone 2 or zone 1. First described by Paulson and Winkler in Denmark, and it is virtually diagnostic of oral contraceptives. This characteristic lesion is seen only under those conditions. It's not common recipients, and it poses no problem unless it somehow represents the precursor of pileosis, and it's not at all clear that that's true. And finally, a word about neoplasms that are drug associated. The most important one, again, I mean, we're giving oral contraceptives a lot of attention to this discussion. Keep in mind that each of the lesions I've mentioned occurs in a tiny minority of the patients who take them. And clearly the benefits have outweighed these disadvantages. But nevertheless, these are lesions with some degree of specificity for that etiology. To come back to it, the tumor most incriminated with drug use is the adenoma. Benign epithelial tumors of the liver were hardly seen before 1960. In the Department of Pathology, in a large active department, they might have had 1 or 2 cases over a period of decades. Since the introduction of oral contraceptives, a lesion has been seen with fair frequency, and probably 1,000 cases have been reported now, and I'm sure many go unreported. 90+% occur in females, during the childbearing years, and 90+% have been in individuals who have been on oral contraceptives, usually for periods at least of 3 years or even longer, occasionally shorter. One may also see adenomas in recipients of anabolic steroids, but less clearly associated than in recipients of the oral contraceptive. Carcinoma of the liver has also been mentioned and associated with each of these agents. There's enough cases have now been reported in recipients of the anabolic steroids to infer an association, and certainly a pertinent topic of today with the widespread use of anabolic steroids for bodybuilding, widespread illicit use for bodybuilding. The question of carcinoma induction by oral contraceptives is not as clear. It's been suggested there has been conversion of adenoma to carcinoma in some patients, in some instances of carcinoma. It's still a controversial point, and the evidence is not clear. And as you know, another tumor that's chemical induced is angiosarcoma. It can be induced by thorotrast and by vinyl chloride, particularly by inorganic arsenic. Well, in the time that remains, I'd like to say something about mechanisms of injury. Chemical agents produce injury because they are toxic or because the exposed individual is unusually susceptible. And susceptibility may be implemented by immunologic mechanisms or maybe metabolic idiosyncrasy. How do we distinguish an agent that is intrinsically toxic from one that depends on idiosyncrasy for its toxicity? Well, I think it's really self-stating. Intrinsically toxic agents produce injury predictably in most individuals exposed to it. Injury is dose-dependent and can be experimentally reproduced. In the absence of these criteria being met, the deduction is that the agent is that the individual is unusually susceptible, the agent is not responsible. Responsible only by being there, but the individual is susceptible. Well, let's first talk about intrinsic toxins. Agents that are intrinsic toxins may produce injury because they are converted to toxic metabolites or because they produce injury without that conversion. Well, carbon tetrachloride, for example, is converted to to a free radical that leads to injury by peroxidation and related changes. Acetaminophen is converted to electrophilic metabolite. These are converted to toxic metabolite. But there are agents that lead to injury without undergoing this transformation. I've listed 3 here: galactosamine, methionine, phalloidin. Tetracycline, not converted to an active metabolite. It acts as such to interfere with the metabolic processes and lead to the fatty liver. Well, if it leads to an active metabolite, how does it produce injury? Well, it may be converted to a free radical that leads to peroxidation, as for example carbon tetrachloride, or the agent may be converted to an electrophilic metabolite, which binds covalently to molecules that result then in necrosis, and acetaminophen, Tylenol, is an example of that. Or it may, in the process of metabolic change, generate active oxygen, which also can lead to peroxidative injury, and paraquat, probably leads to pulmonary and liver injury by that mechanism. Well, as clinicians, what are the criteria that help us decide whether the idiosyncrasy that we see, where there's not intrinsic toxicity, is due to immunologic idiosyncrasy or to metabolic idiosyncrasy? Well, first of all, idiosyncratic injury has a low incidence. Furthermore, it's largely dose independent. But when we see that injury is accompanied by fever and rash and eosinophilia, and when we see that the liver changes include eosinophil aggregates or granuloma, we deduce that the mechanism is immunological. Furthermore, in these individuals, if the drug is readministered, not a very good idea, is readministered, if the injury is promptly reproduced, we judge again it's immunologic in its origin. And it turns out that this injury tends to occur during a fairly fixed period of 1 to 4 or 5 weeks after starting the drug. We call that a sensitization period. There are other drugs that lead to injury just as often, or as infrequently, I should say, also largely dose independent, that are not accompanied by these hallmarks of hypersensitivity, and we deduce that some other mechanism is involved, probably metabolic idiosyncrasy. Furthermore, if the drug is readministered, it now turns out that the injury does not occur immediately, may take long periods before it recurs, and initially the injury occurred weeks or months after starting the drug. Well, let me give you some examples. Dilantin. Dilantin jaundice is accompanied in almost all cases by fever, by rash, by lymphadenopathy, by lymphocytosis, by atypical lymphocytes, eosinophilia. In fact, it looks like serum sickness. And therefore, the inference that immunologic reaction is responsible is a reasonable one. On the other hand, isoniazid toxicity, and we looked at 114 cases of that, was accompanied by these hallmarks in less than 10% and even lower than that for rash. Tissue eosinophilia and granuloma were hardly seen at all. And clearly, the features of hypersensitivity were absent. And some other mechanisms seemed responsible. And turned out isoniazid injury may occur anywhere from 2 weeks to a year after starting the drug. And if the drug is readministered, patients with tuberculosis may be given the drug again when the injury has subsided, not being sure the drug caused it. It takes 4, 5, 6 weeks to recur. Clearly different from the hypersensitivity group. And in fact, there's good evidence that isoniazid leads to necrosis by being converted to a toxic metabolite of acetylhydrazine. Well, what we're saying is that idiosyncratic injury may be due to drug allergy, drug hypersensitivity, or to metabolic idiosyncrasy. The drug would need to be converted to an active metabolite to act as a hapten, to react with protein to form an antigen, or have to be converted to an active metabolite to lead to injury. Conversion to an active metabolite is key. And so what we're saying is that most injury, whether it's intrinsic toxicity or idiosyncrasy, depends on the drug being converted to an active metabolite that may either be the cause of intrinsic toxicity or under certain conditions, lead to idiosyncratic injury, either immunologic or toxic. Conversion is important. Well, a word about metabolism. I'm sure you're all familiar with this, but let me remind you. I have any time left? Let me remind you that drug metabolism converts nonpolar to polar compounds. Its purpose is to permit excretion of a drug. If a drug were water soluble, it would hardly be absorbed. It would have to be lipid soluble to be taken into the body and used. However, if it is not converted to water solubility, it would stay in the body and not be excreted. So the purpose of drug metabolism is to convert the nonpolar to polar compound. It's a two-phase phenomenon. First phase is oxidative and the second phase is conjugative. Oxidation leads to a toxic metabolite. But this metabolite is active so that it can be conjugated in phase 2 and excreted. However, it may also lead to hepatic injury on the way. We call this the toxification part of metabolism and the detoxification. So toxifying reactions are the ones that concern us. Where is phase 1? Where are the phase 1 enzymes, the oxidative enzymes? They're in zone 3 and in the smooth endoplasmic reticulum. And this is why when we see zone 3 necrosis, we deduce that it's due to conversion of the agent to an active metabolite in sufficient profusion to do it. The enzyme involved is cytochrome P450. Let me also remind you that it's not an enzyme, it's a number of enzymes, a whole family of enzymes. At least 20 have been found, and there are probably many more. At least 10 families have been identified, and families 1, 2, and 3 are the ones that are relevant to drug metabolism, and there is substrate specificity, so that a particular compound is likely to be metabolized by a specific isoenzyme, also called isoforms. Turns out that acetaminophen is metabolized by 2E1, one of these, and we'll come back to it. It's an important point, illustrates an important phenomenon. Well, the other part of the phase 2 reactions are conjugations. Glucuronate, dihydrodiol, glutathione, and so forth. This is a very important conjugation. Glutathione turns out to be very protective because when it by conjugation reacts with an active metabolite, prevents necrosis. Well, ineffective conjugation may also lead to trouble. And a man named Spielberg, who was at Hopkins at that time, now was in Canada, 10 years ago demonstrated that patients who develop dilantin jaundice turn out to be unable to detoxify this active metabolite. In special in vitro studies that he did, and I won't go into detail, he showed that patients who have dilantin jaundice cannot convert this to the dihydrodiol. Therefore, this active metabolite may either lead to injury directly or lead to being very active, can be a hapten, and lead to immunologic reaction. Therefore, this even detoxification may be impaired in some instances, even though most of the time we worry about toxification. Well, let me now close by illustrating these phenomena with the fascinating drug, acetaminophen. You all know Tylenol. Wonderful analgesic, antipyretic. It's mild, it's safe, it's widely used. It's a classical hepatotoxin as well. There are at least 125 over-the-counter preparations. It's an important cause of fulminant liver failure. In England, in the UK, it is the most common method of trying to attempt suicide, most common cause of liver failure. And although nowhere near as frequent here, it's had its course here too. As a suicide effort mainly, but also as a therapeutic misadventure. It may lead to trouble even when taken with intent therapy, not just as a purposeful overdose. Well, first let me draw your attention to the fact that most in the instances of attempted suicide, 80% have involved intake of more than 15 grams. Another 10% have taken 10 to 15 grams, and another 10% 6 to 10 grams. These are the identified doses, or estimated doses, that have led to injury in suicidal efforts. How does it do it? Well, acetaminophen is 90%, 95% conjugated immediately and excreted with either sulfate or glucuronate. About 5% is converted to an active metabolite. This active metabolite would react with tissue to lead to necrosis. Were it not for the, is that in focus? No? No. Would you focus it, please? Can you read glutathione? That's what counts. Were it not for the glutathione that's available to detoxify this, this would lead to necrosis. So normally there is little enough of this produced and enough of this present to convert this to the inactive product and prevent injury. When there's an overdose, however, then there's more of it produced and overwhelming the protection, leading to necrosis. But we also have seen evidence of this injury in people who have taken it with therapeutic intent, especially in alcoholics. Aware of at least 50 cases of this, where individuals that develop liver injury when they've taken the drug for hangovers or whatnot. Some of these take too much of it. They're confused, they're careless, they take repetitive doses. Also, they're more susceptible than normals because alcoholics have depleted glutathione. Alcohol induces their P450. You're familiar with induction? Induction of the P450 steps up its activity and it enhances toxicity. When an alcoholic comes in, we can guess that this, not guess, we can recognize this entity because they have towering levels of aminotransferase. Here are 26 cases that we studied. Normally, in the alcoholic with severe liver disease or any kind, the aminotransferase level is maybe 5 or 6-fold the normal. 200, 250, 300, not above that. In severe hepatitis, viral hepatitis, values may be 2,000 or 3,000. In alcohol and acetaminophen, they're over the top. Here are individual cases up to 30,000, 25,000, 20,000. When you see that, you know the diagnosis. And half of the patients had taken doses that would not have been considered toxic, if 1/4 less than 4 grams. It turns out that we can recognize why that happens. Turns out that not, first of all, as I said, acetaminophen is metabolized by 2E1. And studies done in 1984 and since then confirmed many times been seen that alcohol induces P450, especially it induces the same isoenzyme that metabolizes acetaminophen. And it's a precise arrangement whereby alcohol enhances acetaminophen toxicity. Furthermore, let me remind you that acetaminophen injury occurs only when glutathione stores are less than 20% of normal. And glutathione, as I showed you, detoxifies the active metabolite. And it's depleted by alcohol and by fasting. And so the alcoholic has depleted glutathione and has enhanced acetaminophen conversion. So alcoholics get into trouble with acetaminophen. They may take too big a dose. They enhance the activity of the cytochrome P450 isozyme. They deplete glutathione and set the stage for necrosis, as I just said. But remember that alcohol enhances other toxicities. Carbon tetrachloride, exactly the same way. Almost all carbon tet poisoning, most of it occurs in alcoholics. It enhances isoniazid toxicity. In animals, it increases aflatoxin. In the mouse, where you can produce cocaine toxicity, alcohol enhances it. Vinyl chloride, acetaminophen, and others. Well, what I've tried to tell you today is give you an overview of the aspects of injury in man that interest us. And although it is not the area that you look at primarily, it probably interdigitates with it better than it might seem on first blush. And I thank you all for listening.